What if the blood pressure number your doctor told you was perfectly fine is actually damaging your body right now, quietly, without a single warning sign? And what if the number that sent your doctor reaching for the prescription pad was completely appropriate for someone your age and your health history? I understand how contradictory that sounds, but after more than 2 decades of treating blood pressure in adults over 60, I can tell you with confidence that the most dangerous thing about blood pressure is not the number itself. It is the fact that most people, and truthfully many physicians, are interpreting it incorrectly. Here is a number that deserves your full attention. The American Heart Association reports that nearly half of all American adults have blood pressure classified as elevated or high. Among adults over 60, that figure climbs above 70%. 7 out of 10 people your age are walking around with a blood pressure reading that puts them in the elevated or high category. But here is what almost nobody discusses. The Framingham Heart Study, one of the most comprehensive and longest-running cardiovascular investigations in medical history, established that heart attack and stroke risk does not begin at some fixed cutoff point. It rises gradually and continuously, beginning well below the numbers most people consider alarming. The question is not simply whether your blood pressure is too high. The real question, the one that actually determines whether you experience a stroke or a cardiac event or lose your independence, is too high for whom? Too high under what conditions? And too high compared to what baseline? That is precisely what I am going to answer today. And the clarity you gain from understanding these distinctions will be more useful than any single reading your doctor has ever handed you. By the time this video ends, you will understand your blood pressure in a way that most physicians have never taken the time to explain to you. My name is Dr. David Mercer. I am a cardiologist and blood pressure specialist, and I have spent more than 22 years treating hypertension specifically in adults over 60. I have sat across from thousands of patients who were confused, frightened, and deeply frustrated by the conflicting information they had received. Patients who had been told by one doctor that their numbers were acceptable, and by another that they needed additional medication immediately. Patients who were over-medicated and dizzy. Patients who were under-medicated and quietly heading toward a stroke without any awareness of it. That confusion is not the patient's fault. The system that was supposed to give them clear answers has repeatedly failed to do so. Clinical guidelines have shifted multiple times. Numbers considered safe 20 years ago are now classified as dangerous. And the way most people measure blood pressure at home produces readings that are far less reliable than they realize. Today I'm going to clear all of that up, because you deserve a complete picture, not a simplified version stripped of the nuance that actually determines your health outcomes. I will show you exactly which numbers are too high after 60, based on the largest clinical trials ever conducted on blood pressure in older adults, including the SPRINT trial, that fundamentally changed how physicians approach treatment in this population. I will introduce a hidden number that most doctors never mention, one you can calculate from any reading in 5 seconds, that research shows predicts heart attack and stroke risk more accurately than either the top or bottom number in isolation. And I will expose the measurement errors that are causing millions of people to receive false readings, leading either to unnecessary medication or to dangerous false reassurance. Before we begin, if what I share today gives you something genuinely useful, subscribe right now. It takes 2 seconds, and it helps this information reach the people who need it most. Let us start with something most people misunderstand from the very beginning, and that foundational misunderstanding shapes every decision they make about their blood pressure from that point forward. Your blood pressure reading contains 2 numbers. Most people pay attention to only one of them. That is itself a serious mistake, one I have watched lead to outcomes that were entirely preventable. Let me explain what these 2 numbers actually represent, because without understanding this, nothing else about blood pressure management will make complete sense to you. The top number is called systolic pressure. This is the force your blood exerts against artery walls at the moment your heart beats and contracts. Think of it as a wave striking a seawall. Every single heartbeat sends that wave crashing through your vessels, and after 60, 70, or 80 years, those vessels have experienced that impact billions of times. The bottom number is called diastolic pressure. This is the pressure inside your arteries between heartbeats, during the moment your heart relaxes. Think of it as the baseline water level between waves, the constant background pressure your blood vessels experience every second of every hour of every day. Both numbers matter, but after 60, they do not carry equal weight. And understanding why is one of the most clinically important things I can share with you. As you age, your arteries naturally become stiffer. They lose their elasticity and their capacity to flex. When arteries are rigid, the wave produced by each heartbeat hits harder because the vessel wall cannot expand sufficiently to absorb the force. That is why systolic pressure, the top number, tends to rise with age. This is not always a disease process. Sometimes it is the straightforward physics of aging arterial tissue. But the bottom number frequently behaves in the opposite direction. As arteries stiffen, they do not recoil effectively between beats. So diastolic pressure often remains stable or actually decreases after 60. This produces a pattern that is extremely common in older adults and that most people have never had explained to them. It is called isolated systolic hypertension. The top number elevated, the bottom number normal or even low. And this is the single most prevalent form of high blood pressure in adults over 60. Here is where the confusion becomes genuinely dangerous. For decades, physicians were guided by a simple rule. Normal systolic pressure equals 100 plus your age. Under that framework, a 70-year-old with a reading of 170 was considered entirely acceptable. That rule was incorrect, and it cost lives. We now know from large-scale clinical evidence that sustained systolic pressure of 170 in a 70-year-old significantly increases the risk of stroke, heart failure, kidney damage, and cognitive decline. That outdated formula gave millions of people false reassurance while their organs were being silently damaged year after year. But the correction that followed went too far in the other direction. In 2017, the American College of Cardiology redefined high blood pressure as 130 over 80. Overnight, millions of adults who had previously been considered normal were reclassified as hypertensive. Many of them were over 60. Many felt completely well. Many were started on medications they may not have needed. So what is genuinely too high after 60? The most important research answering that question is the SPRINT trial, published in the New England Journal of Medicine in 2015. More than 9,300 participants, the largest and most carefully designed blood pressure treatment trial ever conducted. SPRINT found that targeting systolic pressure below 120 reduced the combined risk of heart attack, stroke, and cardiovascular death by 25% compared to the traditional target of below 140. In adults over 75 specifically, the benefit was even more pronounced, a 33% reduction in cardiovascular events. But, and this is absolutely critical, aggressive treatment came with real consequences. More episodes of fainting, more electrolyte disturbances, more kidney complications, more falls. In older adults, a fall caused by medication that pushes blood pressure too low can be just as life-threatening as the elevated pressure it was meant to treat. Which means the conversation about blood pressure targets is far more nuanced than most clinical visits allow for. There is no single number that applies equally to everyone. The right goal depends on your age, your general health, your specific risk factors, your history of falls, and how your body responds to treatment. But I can give you the specific ranges that the evidence supports. For adults between 60 and 75, systolic below 130 at rest is the ideal target. 130 to 139 is acceptable if you feel well and tolerate it. 140 to 149 warrants monitoring and focused lifestyle changes. 150 or above consistently at rest needs attention and a conversation with your physician. For adults over 75, below 140 is the general goal. 140 to 149 depends heavily on how you feel and what your fall risk looks like. 150 or above consistently is too high regardless of age. For diastolic, below 80 is ideal. 80 to 89 warrants monitoring. 90 or above consistently places damaging ongoing strain on your arteries and organs. Now, the hidden number I promised you at the beginning of this video, a third figure you can calculate from any reading in 5 seconds. Research shows it predicts heart attack and stroke risk more accurately than either the top or bottom number by itself, particularly in adults over 60. It is called pulse pressure. Pulse pressure is simply the difference between your top and bottom numbers. A reading of 150 over 70 gives you a pulse pressure of 80. A reading of 130 over 80 gives you a pulse pressure of 50. Why does that gap matter so much? Because pulse pressure directly reflects arterial stiffness. Stiffer arteries drive systolic pressure higher while allowing diastolic to drop lower. The gap widens. And that widening gap is one of the clearest cardiovascular warning signals available in older adults. A landmark study using Framingham Heart Study data found that pulse pressure was a stronger predictor of cardiovascular events than either systolic or diastolic alone in adults over 60. Stronger than either number in isolation. Below 40 is within the normal range. 40 to 60 is acceptable but worth tracking over time. Above 60 is a meaningful warning sign of significant arterial stiffness and elevated cardiovascular risk. If your reading is 160 over 70, most people fixate on the 160, but the pulse pressure is 90. That number tells you your arteries have lost critical flexibility and your heart is working under dangerously high resistance. Now, something that almost no physician discusses openly with patients over 60, yet something just as dangerous as pressure being too high: diastolic pressure that has dropped too low. In older adults, diastolic consistently below 60 carries genuine risk. A study published in the Journal of the American College of Cardiology found that adults over 60 with diastolic readings consistently below 60 had meaningfully increased risk of cardiac events because pressure between heartbeats was insufficient to supply the heart muscle with adequate blood flow. I had a patient I will call Walter, 74 years old, a retired mechanic, managing his blood pressure with 3 separate medications. His systolic was well controlled at around 128, but his diastolic had fallen to 52. He was dizzy every time he stood up. He had fallen twice in the previous month. Walter was not in danger of having a stroke. He was over-medicated. His diastolic had been pushed so low that his heart was not receiving adequate circulation between beats. We carefully reduced one medication. Within 3 weeks, his diastolic had returned to 68. The dizziness resolved. The falls stopped. His blood pressure remained appropriately controlled. His prescribing physician had been so focused on the top number that nobody had noticed the bottom number had become dangerous. Do not only watch the systolic. Do not only watch the diastolic. Both halves of that number tell part of a story that neither tells completely on its own. Calculate the gap between them and verify that the bottom number has not fallen below 60. Too low can be just as harmful as too high. Before I show you the measurement errors, I want to ask you something directly. Do you know what your blood pressure actually is today? Not from a reading taken months ago in a waiting room. Today. Have you ever calculated your pulse pressure? Go to the comments right now and tell me what your numbers are. I read every single comment on this channel, and I will respond to as many as I can. Let me now show you the measurement errors that are giving millions of people completely inaccurate readings. These are not minor imprecisions. They can add 10, 20, even 30 points to a reading. Those extra points are the difference between leaving an appointment reassured and leaving with a prescription you do not need. Error number 1. Measuring without resting first. You arrive at the doctor's office, walk down a corridor, climb onto an exam table, and within 60 seconds, a reading is taken. That reading is almost certainly elevated above your true baseline. Research published in a hypertension journal found that blood pressure taken without a minimum 5-minute rest was 10 to 15 points higher systolic than after proper rest. That is the difference between 138 and 148, between acceptable and classified as elevated, between watching and treating. Error number 2. Talking during the reading. Studies found that speaking during measurement raised systolic readings by 10 to 15 points. The clinician asks how you have been feeling. You answer naturally. The reading climbs. Nobody connects those two events. Error number 3. Crossed legs. Research found that sitting with crossed legs raised systolic readings by 5 to 8 points. Combine this with no prior rest and a conversation during the measurement, and you're looking at 25 to 35 points above your actual pressure, enough to completely change the clinical picture. Error number 4. The wrong arm or the wrong cuff size. Blood pressure readings can differ between arms by 5 to 10 points. Measuring only one arm consistently produces a skewed picture, and a cuff that is too small for your arm size inflates readings artificially. Cuff fit is almost never checked in a standard clinical visit. Error number 5. White coat hypertension. Blood pressure that rises specifically in a medical environment due to anxiety, your conscious mind may not even register. Your body reacts automatically. Adrenaline releases. Heart rate increases. Pressure spikes. A meta-analysis found that white coat hypertension affects 15 to 30% of adults diagnosed with hypertension. As many as 1 in 3 people currently being treated for high blood pressure may not have it at rest outside a medical setting. This is precisely why home measurement matters and why measuring correctly at home is essential. Here is the protocol I give every patient over 60 who comes to me wanting a genuinely reliable picture of their resting blood pressure rather than a snapshot taken under conditions that were never controlled. Sit quietly for a full 5 minutes before taking any reading. Feet flat on the floor, back fully supported. Your arm resting at heart level, not hanging at your side. Bladder empty. No talking, no phone, no background television. Take 2 readings 1 minute apart and use the lower of the 2. Write both numbers down. Do this twice daily. Once within 20 minutes of waking, before coffee or food. Once in the evening before bed. Alternate arms every other day. Do this for 7 consecutive days. That gives you 28 separate readings taken across a full week under consistent conditions. Average them all. That average is your true resting blood pressure, and it is the number that should inform your treatment decisions, not a number taken after rushing across a parking lot, not a number taken during a 3-minute clinical visit. Your actual baseline. If that average is consistently above 150 systolic or 90 diastolic, that is too high and requires a serious conversation with your physician. If it sits between 130 and 149, bring those 28 readings to your next appointment. They are worth considerably more than any single reading taken in an exam room. Now I want to address the question I hear most consistently from patients over 60. When does a high blood pressure reading become an emergency? When do you call emergency services versus sit down and monitor? What symptoms turn a high number from something worth watching into something that could harm you within hours? Here is what most people misunderstand about blood pressure emergencies. A high number by itself, even a very high number, is not automatically a crisis. I know that may sound counterintuitive, but let me explain. You take your reading at home and see 170 over 95. Your immediate response is to reach for your keys. In some situations, that is exactly the right response. But in many situations, that number reflects a temporary spike caused by stress, pain, caffeine, or simply the anxiety of taking the reading itself. So how do you distinguish a spike from a genuine emergency? The answer is symptoms. A high number without symptoms is a signal to sit down, rest, and monitor closely. A high number accompanied by specific symptoms is a signal to act without delay. The symptoms that convert a high reading into a medical emergency are these. If blood pressure is above 180 systolic or above 120 diastolic, and you are experiencing any of the following, call emergency services immediately. A sudden, severe headache unlike anything you have felt before. Chest pain or pressure, new or worsening difficulty breathing. Any change in your vision, including blurring or partial loss. Difficulty speaking clearly or sudden confusion. Numbness or weakness on one side of your body. These are signs of hypertensive crisis. Blood pressure actively causing organ damage in real time, affecting the brain, the heart, the kidneys, and the eyes. Research found that untreated hypertensive crisis carried a mortality risk of up to 25% within the first year. 1 in 4. That is a genuine emergency, and time matters. But here is the other side of that equation. If your reading is 170/95 and you feel completely well, no headache, no chest discomfort, no visual changes, that is not an emergency. That is what physicians call an urgency. There is a clinical distinction between those two classifications. Sit down. Rest for 5 minutes. Breathe slowly and fully. Retake the reading. In the majority of cases, with genuine rest and slow, deliberate breathing, it will drop 15 to 25 points within 10 minutes. If it remains elevated after proper rest, contact your physician that same day or the following morning. I had a patient I will call Dorothy, 68 years old, a retired teacher. She called me alarmed. Her home monitor had read 182/98. She was already putting on her shoes to drive herself to the emergency department. I asked her 3 questions. Any headache? No. Chest discomfort? No. Vision changes? No. I asked her to sit down, close her eyes, and breathe slowly for 10 minutes. Then retake the reading. She called back 14 minutes later. The reading was 148/86. Still elevated, but nowhere near crisis range. She had taken the first reading immediately after a heated telephone argument. Her body had flooded with adrenaline. Her true blood pressure was never 182. Her reactive blood pressure in that moment was 182. Dorothy did not need an emergency room. She needed 10 minutes of stillness and a few slow breaths. This is the critical lesson. We do not treat individual readings. We treat patterns. One high reading tells you something. 2 weeks of high readings tells you everything. One elevated reading is a data point. 14 consecutive days of elevated readings is a pattern that demands intervention. Know the difference between the two, but also know absolutely when to act without hesitation. Above 180/120 with any of those warning symptoms, do not rest and recheck. Call emergency services immediately. Minutes genuinely matter in that situation. Let me bring everything together now because I want you to leave this video with something more useful than a set of numbers to memorize. I want you to leave with the kind of clarity that gives you actual agency over your own health decisions. Here is what you now understand that most people your age have never been clearly told. Your blood pressure reading contains 2 numbers with different clinical meanings that shift in importance as you age. The systolic top number rises with arterial stiffening and matters most after 60. The diastolic bottom number must not be allowed to fall below 60, a danger that is frequently missed. You know the evidence-based ranges. For adults 60 to 75, systolic below 130 is ideal. 130 to 139 is acceptable. 140 to 149 requires attention. 150 and above consistently is too high. For adults over 75, below 140 is the goal. 150 and above consistently is too high at any age. Diastolic 90 or above consistently is too high at any age. You know how to calculate your pulse pressure in 5 seconds from any reading. Below 40 is normal. Above 60 is a warning sign of meaningful arterial stiffness and elevated cardiovascular risk. You know that blood pressure varies throughout the day in response to stress, movement, caffeine, and rest. A single elevated reading is not a diagnosis. A consistent pattern is. You know the 5 measurement errors that can inflate readings by 25 to 35 points and lead to treatment decisions based on numbers that were never accurate. And you know the correct home measurement protocol that produces a reliable 28 reading baseline worth more than any single office measurement. You also know the difference between a blood pressure spike and a hypertensive crisis, and you know exactly which symptoms require calling emergency services without delay. In more than 22 years of clinical practice, the single greatest obstacle I have seen stand between patients and good outcomes is not blood pressure that is too high. It is patients who do not understand what their numbers mean. Patients who are frightened of readings they cannot interpret. Patients over-medicated because their office readings were never accurate. Patients undermedicated because their true pressure was never properly measured at home. Understanding your numbers does not generate fear. It replaces fear with the capacity to make genuinely informed decisions based on what is actually happening inside your body. To ask the right questions of your physician, and to interpret the answers you receive with real understanding. To recognize when to act and when to breathe. What is your blood pressure right now? What is your pulse pressure? Take a reading tonight using the protocol I described. Sit for 5 minutes first. Breathe. Then measure. Calculate the gap. Then come to the comments and share what you find. I read every comment, and if you share your numbers, I will do my best to help you interpret what you are seeing. If this video gave you something useful, something that reframes how you understand and monitor your own numbers, do 3 things. Subscribe to this channel, hit the like button, and share this with one person over 60 who has been confused or worried about their blood pressure numbers. You may give them a clarity that genuinely changes how they understand and respond to their blood pressure from this point forward. Blood pressure is not a mystery. It is not a sentence handed down without appeal. It is a signal, and now you know how to read it accurately, measure it correctly, and respond to it appropriately. I am Dr. David Mercer. Take care of your heart, because everything else depends on it. This content is for educational purposes only and does not constitute medical advice. Always consult your physician before making any changes to your medications or health routine.